Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on the surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I'm looking forward to our discussion on the recently published article in SurgiColl titled Wide Awake Surgery, a review of cost savings potential. In addition to discussing this article, we will do a deeper dive on wide awake surgery in general. For this episode, I'm excited to be joined by my friend and colleague, Dr. James Clarkson. Dr. Clarkson is a plastic and reconstructive surgeon who trained in England and Canada, followed by a hand surgery fellowship from the renowned Kleinert Institute in Louisville, Kentucky. Dr. Clarkson has spent the past 15 years as faculty at the Michigan State University, where he has helped establish the hand management unit and has championed wide awake hand surgery in the office setting. He has extensively published in wide awake surgery and has pioneered virtual reality as a distraction technique for office surgery. So first off, Jamie, thank you for joining me.
Hi.
So before we get into the article, Jamie, it's always fun to get started with some warm-up questions for our listeners to get to know you a little bit. So first of all, tell us a little bit about what drew you to your surgical specialty of plastic surgery.
Yes, stories from my family. My grandfather was a plastic surgeon. He was super inspired by the guy across my shoulder here. This is a guy called William Lane, who was the developer of sterile technique, also the discoverer of Harold Gillies, who's the father of plastic surgery in World War I. He was the surgeon responsible for giving him a plastic surgical unit to start the discipline in. So it's kind of a big shoes to fill.
Indeed. Well, then what about, let's go a step further. So we all know that hand surgery is a subspecialty of plastics, orthopedics, general. What drew you to hand surgery ultimately?
Absolutely. Well, hands in its own right within plastics, I think, was the most practical way I could apply what I do to the most patients. It's desperately needed in every community. And as I settled in the United States, my wife put me on the spot and said, I want a career. She said, I want to work in a university. And I said, well, I wonder what jobs they've got going in universities. And lo and behold, an awful lot of those jobs are hand jobs. So, and also the functional outcome aspect of it. The aesthetic mission for plastics has never really been my thing. It's always been about reconstructive form and function.
Got it. So clinical research, one of the things I've been impressed with in your career is the work you've done in research, particularly clinical research focusing on wide awake surgery, office surgery. You've done some important leading work in that space. What drew you to doing research?
Again, big shoes to fill. If you really want to try to take your discipline seriously, you've got to engage with the world outside of your specialty. And that's sort of been the focus of I'd say for the last 10 years of my career. I've just been focusing on that interface between how we can deliver the best care in the world that we live in, and what aspects of that world can we influence as surgeons, which is becoming an increasingly difficult subject for all of us.
Yeah, indeed. Research is obviously SurgiColl is a scientific journal, so it's a premise of why we're even talking today. But I think that those of us who perform clinical research really get the importance of it in terms of advancing what we do and really shaping what we do and also educating the next generation and innovating, et cetera. So I admire you for doing it, and I thank you for doing this. One more question, though, James, before we get into the article itself that we're going to talk about. One of the fun things we ask is, what's your favorite or most hated movie or TV show? We generally focus on one that's medically oriented, but doesn't have to be. So is there one that you want to talk about that you really love?
I picked a science fiction one. I don't really watch medical TV shows too much. So mine is Gattaca, because no one has the right to tell you what to dream.
That's the one with Ethan Hawke, correct?
That's correct.
What was
He
the
is
premise of that one?
well, he's an imposter. He's an imposter in a world where everybody else appears to have an advantage, a genetic leg up in life. But he's got ideas well outside of his station, several pants bigger than he can wear, and he pulls it off. I always like that movie for that reason.
I did see that movie a long time ago, but I admittedly am not remembering it. But it was something he was disadvantaged in a world where people had significant advantages from a tech perspective, I think.
Well, they were genetically enhanced. It's a 1997 movie before the Human Genome Project was finished, so it was all very speculative. And everyone else had genetic enhancement. It's a little bit like discovering everyone else had a very much higher score than you do in step one. And but then he made it anyway.
Got it. Okay. 1997. Okay, I'll have to go back and maybe brush that one off and watch that once more per your recommendation. So, Jimmy, let's get into the article that was published in SurgiColl this past issue. And first, two disclosures for our listeners. First, I co-authored this paper with Dr. Clarkson because this topic of wide awake surgery is also one that's very near and dear to my heart as well. And I'm also with yourself, Jimmy, with Dr. Clarkson, I'm also engaged in a new company that we have called Wallon Surgical Solutions. So I want to put that disclosure out there. But what we're going to be talking about relative to this paper is really just the concept of wide awake surgery and some of the cost benefits and why we think that there are some real opportunities from a societal perspective. So Jimmy, let's get started in the article. So in the article, we discuss cost savings around wide awake surgery. But I think it's important to define for people when we say wide awake surgery, what are we talking about? How would you tell the listeners what that concept is?
Yeah, the origin of this, strictly speaking, is from Dr. Lalonde's work, pioneering really from about 2005. He's proselytized this throughout all the meetings, and all our surgical education programs have had a good dose of Wellant training now for about 20 plus years. And it involves no use of oral sedatives. It involves pure use of tumescent local anesthetic in order to achieve complete local anesthesia while the patient remains completely aware without sedation.
Yeah, and just for background, Dr. Lalonde is a plastic surgeon from Canada, also specializing in hand surgery, and also was our guest editor for this issue. So he wrote an excellent editorial around the power and impact of wide awake surgery. Whenever we talk about this, I always find it such an interesting topic because in its core, it's very basic, right? We're just basically talking about performing surgery without your standard anesthetics that we use pretty routinely, from the general anesthetics to the intravenous anesthetics to the inhaled anesthetics. We're talking about just using lidocaine, right, in the surgical field, which really isn't novel by itself. We've been doing that since anesthetics have revolutionized medicine surgery a long time ago. But in the world of, say, hand surgery and a lot of the specialties of orthopedic surgery, maybe less so plastics, but definitely ortho, the concept of doing surgery under straight lidocaine is uncommon, in contrast to, say, I feel like maybe plastic surgery or dermatology, where it's more commonplace.
Yeah, right. And it's, well, so orthopedics and general surgery and plastics were really born within the operating room. They don't predate the operating room. And the operating room evolved with the presence of anesthesia, sort of 1900, that the great industrial revolution of medicine. So yes, it has taken, it has had to take hand surgery by surprise when perhaps oral surgeons, dentists, dermatologists, ophthalmologists, even urologists were doing a great deal of the mucosal surgeries, really before we had sterile techniques. So for those specialties, awake surgery is kind of more germane. And it's the way we've been bundled over really 125 years it's actually kind of a fascinating cultural event in its own right.
Indeed. But as for me, as an orthopedic surgeon, I can tell you that it has been a cultural shift. And when I talk about this with my peers and other orthopedists who do wide awake surgery talk about it, it is a cultural shift. And I mean that cultural from a training perspective and a practice perspective, not like an American versus another country perspective, but truly like a surgical culture perspective. Orthopedics has been one that has always embraced work in the operating room setting, but we're seeing that shift. And that's one of the questions I want to talk about is we're seeing more and more cases shifting from the main operating room to, let's say, HOPDs, which is short for hospital outpatient departments, which is then the next level is ASCs or ambulatory surgical centers. And then more recently in the office setting, which I want to talk to you about because that's something that you really championed. But just to lay a little bit more background for everyone, that transitioning is happening, and that transition over time has been happening. Actually, in my own career of almost 20 years now, I've been seeing that happen rapidly. And that's really been driven by a combination of efficiency and cost savings. Because hospitals are inherently, for better or for worse, whether they want to or not, relatively inefficient because they're trying to do many things, big, small, complex, not complex, and try to be all things to all people, and are also more expensive because of the extent of resources. So shifting things down to more efficient settings in ASC and now perhaps the office makes sense. And specialties like hand surgery have been early in that process of that transition, and other specialties as well. But there's others coming later now that are following, which I would have never thought that would be the case, such as joint replacement surgery and spine surgery shifting to the ASCs. So when you move your practice, Jamie, from the hospital or ASC to an office setting, what was your reasoning from that, and what did you learn from that process?
I deliberately did it. It was a deliberate experiment, actually. I had been working doing microvascular, very major head and neck reconstructive cases in that usual way in which so many plastic surgeons can get very caught up with the institutional nature of our surgical discipline. And our head and neck surgeon left, and that gave me a window of opportunity to return to my core area, which was hands. And I had a choice to make. I could continue with my block time in the main operating room. I could continue with business as usual, allowing anesthesia to dictate whether the patient was going to be given an LMA, an ET tube, or simple MAC and sedation, and really have very little control over that, plus the inefficiencies, turnover time. Or I could do something that I really passionately believed in, which was that patients actually choose to come to see us as a hand surgeon in an office environment. They didn't walk into the hospital looking for surgery. And I think that's a super important point, because as surgeons, we still have an agency in what happens next. And I introduced my patients to two choices. You could go to the hospital, or you can stay in the office and we can do this carpal tunnel, trigger finger, whatever have you, in the office environment. And around about 30% of them were still choosing to go to the operating room. And I had other cases that I do, other plastic surgical stuff, and it was becoming quite inconvenient to me, to say the least, to add these extra triggers to the end of these other schedules, my other general plastic stuff. And I began to take more note of the weird complications that I would see in the main operating room. And no kidding, I saw a minor stroke. I had a chap having a relatively minor surgery. It wasn't a hand surgery, it was a minor leg wound issue, developed a significant chest infection. And another chap with a leg flap that developed a really major complication. I had a myocardial infarction and passed away. And so I began to look at the operating room as a place that was really a massively privileged place to take patients. And so I would back pressure onto my hand patients and say, look, why are you not considering the operating room? How can I help you? And that was why I broke open the virtual reality headset, which was just coming out at that time. And it allowed that conversion of that last 30% of patients. So suddenly all of them could now be operated on in my office. And suddenly I was able to get all my work done almost immediately. I mean, the whole week opened up for me. My RVU generation, which was how we're measured at the university, went through the roof. I've developed Friday afternoon off, which is never harmful for your health. And my patients began to seek me out in ways that I had never had before. That my best referral base was now my last patient. It wasn't the hospital system. It wasn't the university system. It wasn't my physical medicine and rehab referral loop. It was now my patients. And so I thought I'd better look at this more analytically, and we looked at the infection rates, and what we found was that our infections were in fact lower or the same in the office. So I realized that there wasn't really an infection issue. We looked at patient satisfaction, and it was dramatically higher in the office environment. And when you used virtual reality versus not using virtual reality, there was also a lift. And then the last thing, and the fun thing, genuinely fun thing, was that my patients started reporting something that never gets reported in outcome studies. They started reporting pleasure, joy. So I started measuring joy, and what we were finding was that patients were having a more enjoyable time when they were watching shows with the educational component that I was giving them through VR. And so I took this step by step, and we published each step of the way over the next 5 years. And that was how I transitioned from the main operating room into the office. One long, glorious experiment that was really good fun.
Well, I really value that experience and the fact that you chronicled it with your research and continued to advocate for it. It is an evolution, I think, and I think some individuals like yourself are at the tip of the spear, kind of advancing this. But I do think everyone's coming, by the way, one way or the other. I just think that the tide is such that we're heading in this direction. In my own experience, I was heavily working in the operating room setting for the early part of my career, main operating room setting. And it's one of those things that once you get exposed to an ASC setting and you see the efficiencies, you can't help but want to be there because things move quicker. And listen, time is a finite resource that we're always striving to protect. So that efficiency that is driven by it is so paramount, and then control as well. And I think transitioning the office is only going to continue that paradigm. When I look at this process, I look at this transition from the operating room to the surgical centers and now the office is pros and cons to multiple groups of people. So, firstly, I think first and foremost is from the patient's perspective, enormous advantages in terms of convenience, cost savings, complication risks, and comfort. And you touched upon all those things, and we can do a little bit deeper dive on all of those things. From the payers, it's a huge cost saving. That's what we talked about in this paper, is enormous cost savings when you move patients out of these centers, because the facility fees are extremely high in the hospital setting, high but not quite as high in the HOPD setting, less high in the ASC, and non-existent in the office setting. And then you throw in the professional fees for the anesthesia, and no knock to our anesthesia colleagues, but when their services are not needed, you don't need to expend those costs. And then the other savings is all the pre-admission work that needs to be done for standard surgeries. And unfortunately, whether you're having a small surgery like a trigger finger release under sedation or a large surgery like a multi-level spinal fusion, the preoperative evaluation is almost identical. And if you're having even a whiff of anesthesia for a trigger, so you're getting your blood work, your EKG, your primary seeing you, maybe they're sending you to a cardiologist, maybe you're getting an echo, and yada, 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 kind of the list goes on. And when you do these patients under straight local, you don't have to do any of those things and can proceed in a safer and simpler way. And then I think from the surgeon's perspective, the enormous control that it confers, the efficiencies that it confers, avoiding so much of the hospital and ASC bureaucracy, and then really maximizing the surgeon-patient engagement, right? It's just you and the patient. They're learning from you. They're getting all their information from you. You're able to communicate with them during the operating room, afterwards, et cetera. It's really, I think, amazing in terms of dynamics. But that being said, Jamie, I think a lot of the reticence for a lot of doctors has been around the importance of sterility and the fact that if you're going to place an incision, it's got to be in a super sterile environment. Otherwise, you're going to have all of these complications. What's been your experience with that? I know you've looked at this.
Well, I mean, the infection rate was no different. And when it comes to culture, I'm not so sold that surgeons are more worried about infection as I am that simply the dollar isn't following the patient.
Mm-hmm.
So I've done some fairly gross calculations as to how much money I might have saved payers since 2016. And I've estimated that I've saved them somewhere between $15 and $25 million. Now, where is that money now? Well, it's in the pockets of United and Blue Cross and Blue Shield and CMS, because this is money that was allocated to be spent on those cases, but that simply didn't get spent. And I think that's really the last breadcrumb on the street to getting patients into the office environment, is for some of that money to be shared with the clinical team, the surgeon, their office expenses. If you're going to save a payer $5,000 on a carpal tunnel release, it's only reasonable that some of that will come with the patient to the office environment, which will lift the surgeon's fee and allow them to use better instrumentation, perhaps some of the more expensive instruments that are otherwise only available in the hospital. And I think that's our last ingredient, really. Don't you agree? I think that's
that was the big takeaway the conclusion we came to, is that the cost savings of taking a case from the OR to the ASC is significant, and then to the office even more significant. And then doing them awake obviously completely eliminates those facility fees. But right now, what we learned and what we laid out in our paper is that the paradigm is such that there's no current incentivization for surgeons to do that for the most part. So if a surgeon is getting paid the same amount wherever they do it, they may not feel inclined to take on the responsibility of creating a surgical suite or a surgical space. You have to buy gauze and sutures and lidocaine. You have to help train up your staff. And so there's a mismatch right now. And currently the current paradigm doesn't really incentivize the payers to support the surgeons who are taking on that style of care, which is better for everyone involved, and first and foremost the patient and the payer. So that's, I think, the disconnect, right?
It is. And not only that, there's perverse disconnects. I mean, it gets worse than that. Medicare Advantage frequently won't fund deeper tissue work above the wrist. So I'm forced to take a cubital tunnel to the main operating room, whereas I would be allowed to do a carpal tunnel in the office. Luckily this year, the basic CMS site of service code, which is number 11 for the office, actually recently radically expanded the codes that it was prepared to pay for. There had been a moratorium on doing dupotrons, for example. It was hard to always get paid. Sometimes you would, sometimes you wouldn't. Now it's 100% listed online on the CMS website as available. Now that, again, isn't the commercial version. All those Medicare Advantages are in fact commercial products, so they can still have their own individual policies that are pro-complexity, pro-ASC and hospital outpatients department, which is another argument we don't really understand. We won't have the time to go into that argument as to why they'd want to over-complexify care. But just on your Medicare alone and commercial payers, even without a lift in the fee, pure rugged efficiency is still a business positive position to take when you're trying to do patients in the office environment. And for example, if you already happen to have passive income from an ASC, it still makes good logical sense that the efficiency with which you can drive those cases through your office to liberate an operating room for a major shoulder arthroplasty is still tipping the balance in favor of doing office surgery. We're just not quite there in terms of the financial difference, but it's close. You can run a very good business just doing at cost office-based hand surgery now, just simply because every half an hour you get 100% of the next code that you operate on.
I think that, inevitably we'll continue to see this transition to ASC and office settings. I just think that the math and the economics is so clear. The demand for not only cost savings, the demand for efficiencies, the demand for more options for patients, the demand for just more care, it continues to grow. The population grows, surgical offerings grow, problems grow. The public are more active and doing more. I just think it's going to happen inevitably. And I think work like this and others are important to show objectively what the potential is. And I look to someone like you, who a single surgeon in one town, in a very large country, can save the system $25 million over 6 or 7 years. If you extrapolate that out, it's an enormous cost savings to the system. And unfortunately, it can take a while for these things to percolate and for health systems to change. They're big and they are not agile. There's a lot of conflicting interests. There's a lot of entrenched interests that you have to redirect, if you will. But I think it's going to happen. But I think continue to produce research around this makes sense. And I think it's important for surgeons to lead, advocating for efficiency, advocating for improved patient outcomes, improved safety, decreased costs, but also advocating for themselves to have, we're in a world where everyone's getting paid less while things are getting more expensive. It only makes sense to advocate for one's abilities and skills and talents, and also to be appropriately compensated for this, and also maximize control, maximize efficiency, and what have you. So I think it's going to happen, Jamie. Papers like this, I think, help. The work that you're doing, absolutely, I think will make a difference. And I think it's important to share that work and for people to think about, well, what could I do differently to provide better, more efficient, more cost-effective care?
I agree. And let's not forget the patient experience at the heart of this. Patients don't, especially since COVID, don't really want to go to the operating room. There's certainly a connotation, specifically with the hospitals. And my patients are also becoming aware of the nature in which they're being advised is not always in their absolute cleanest best interest.
Indeed. Well, let's close out this discussion on a question, if you don't mind, Jamie. So what do you think are some important future directions for research on this topic for yourself and for others around wide-awake surgery and or cost savings in surgery in general?
Yeah. I mean, I've spent a lot of time looking at the patient experience as one of those areas, and I still see that as something that as a discipline we have to recognize is wide open at the moment. Up until now, patients have been obtunded. Now we are responsible for the stream of consciousness from the minute they walk into our clinic for a diagnosis to the minute they walk back out to their car after surgery. So we do need to look at the science behind patient education, the science behind a patient response to treatment, how they can experience essentially being cut on wide awake, and what ways in which we can help. And as you know, I use technology with that, but I think there's other methods. There's a very inspiring surgeon in Montreal called Jean-Paul Boutus, who also has taken extreme focus on this. And I've been to his operating room where patients are given a light show, they're able to choose music, and they really did seem to be having a good time. I watched him do several cases. There was a real sense of something special going on there. And that is a two-way street. The happier and healthier your patient is, the happier and healthier you and your clinical team are. But there are things that we're going to need to work out. For example, how do you then teach? How do you teach a resident on a patient, who drops a stitch or who needs to be guided or have something redone? And again, those are the reasons why distractive technologies, I think, have a place. I think we still have to evolve. The technology always needs to be streamlined and improved. But for a training program to occur on an awake patient, there has to be a cultural shift in the patient population, and there has to be perhaps some form of gentle veil so that they're not absolutely aware perhaps of every cut, every bite of the needle. There has to be some averaging of the experience. So I've found VR to be useful for that. And then finally, of course, what can we do wide awake? And we know from Dr. Ahmed in Malaysia, you can do everything from an open fracture ankle fracture or through to a clavicle. I mean, there's just so much that you can do under local. The big question is, where does that stop? And where is the sterile sciences going to stop on the subject of how clean do we really need to be? And I've looked into those, some of the historical papers into this. There's really good evidence that you need sterile technique for the implementation of plates and screws. That's really why this guy invented it in the first place. He put the first plates and screws in. But now that we have antibiotics, now that we've got good, clean prep technique in the office, how sterile do we have to be? What is the real science behind the JCO regulations? And when I looked at those, we found about 300 papers almost totally without any evidence that any of these events led to infection, which meant that there's almost no evidence for sterile technique at all. And I think that, that's a huge industry right there that we can reduce expenses on.
I mean, there's so much you covered there in terms of next steps. And that's one of the great things, I think, for those who study surgery and the surgical sciences, is we often focus on the anatomy and the surgical technique, but there's so much interplay of everything else around you, from implants to the sterile process, through patient flow, through training of doctors, nurses, and techs of all sort around the patient care experience. And then fundamentally, and then costs, obviously, like we started the conversation with, but also you touched on the importance of the patient experience, which often takes last place in this, with the assumption is as long as you have a good outcome, it doesn't matter, what the patient thinks. And perhaps that's true. But you and I have talked before. We both recently have had surgical experiences, and that we were both, as surgeons, we were like, boy, that was unpleasant, I think, to say, to be brief about it. And so there's so much room for improvement. And I think that as long as we continue to innovate and look at this, not dogmatically, but critically, and always questioning, and also always seeking the best evidence, I think, we'll continue to improve. And the work that you're doing in wide awake surgery, the work you're doing and driving surgical cases that are able to be done under not only in their local, but in the office setting for the reasons of cost and savings and efficiency is wonderful. So I thank you for that work, Jamie. I thank you for teaching me this as well, and mentoring me in this space. But with that, I think we'll wrap things up. I'm just going to make a couple closing comments, if that's okay.
Yeah, great.
But thank you, Jamie. So I want to thank you for the discussion and your expertise. And in closing, at SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down. It allows the authors to maintain the ownership of their work. And most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world, with no requirements to purchase access or pay for a subscription. Thank you for joining us. Till next time.